Welcome back. In this lesson we're going to learn about the adrenal and pancreas glands. The adrenal glands sit adjacent to each kidney. In this figure you can see the location of the right and left adrenal glands. Please notice how good their blood supply is, very typical for an endocrine organ. The adrenal glands are subdivided into an outer layer called the cortex and an inner layer called the medulla. You might remember we use these terms in relation to the brain and other organs as well. The cortex provides steroid hormones, which are called the corticosteroids because they're produced by the cortex. The inner layer, the adrenal medulla, is an extension of the nerve tissue of the sympathetic nervous system. When you look at the tissue within the adrenal medulla, you can identify the neurons that are secreting what in any other tissue would be neurotransmitter, epinephrine and norepinephrine, but because they're being secreted by neurons into the blood, they're considered neurohormones. In this view you can see again how excellent the blood supply is and how distinct the cortex is from the medulla. The adrenal cortex itself is divided into three layers. These are called zones or zona in Latin. The zona glomerulosa, the zona fasciculata, and the zona reticularis. In this photomicrograph you can see the layers. Get your bearings. It's kind of upside down to the way you would want it to be. The capsule, the outer part of the adrenal gland, is at the bottom of this figure. So the zona glomerulosa is the part closest to the outside. The medulla is the top in this figure, and the zona reticularis is a very narrow band of tissue here, with the zona fasciculata being the thickest band in the middle. The zona glomerulosa cells produce a group of hormones we call the mineralocorticoids. They're called that because they regulate the minerals, sodium and potassium. Now, there are some minor hormones in this group, but the major one, and the only one you need to remember by name, is aldosterone. In the name aldosterone, you see the term steroid, so you would never have to guess whether this is a steroid hormone or not. Aldosterone is a steroid hormone that conserves sodium ions and eliminates potassium ions. Its main job is to make sure you don't run out of sodium, but at the same time that you don't have an excess of potassium. So you secrete aldosterone when your sodium levels in your blood are too low or the potassium levels are too high. Aldosterone's role in regulating sodium and potassium levels is also going to be important in blood pressure regulation. So we find that in addition to being regulated directly by sodium and potassium levels, aldosterone is very sensitive to changes in blood volume and blood pressure. Our second layer, remember this is the thickest layer, secretes our glucocorticoid hormones. Again, you see some hints in the name as to what the role of this hormone is. Gluco because they regulate glucose, cortico because they're in the cortex, and the oid at the end reminds you that these are steroid hormones. Examples include cortisol, which is another name for hydrocortisone, and corticosterone, and a third hormone, cortisone, is actually converted by the liver into its active form. But you have three main glucocorticoid hormones. These hormones are for the most part regulated by negative feedback, and we talked about this before when we were talking about the role of the hypothalamus in the anterior pituitary. Remember that the hypothalamus secretes releasing hormones. Corticotropin releasing hormone stimulates the anterior pituitary, or adenohypophysis, to secrete adrenocorticotropic hormone, ACTH, and ACTH travels through the blood from the pituitary. When it gets to the adrenal cortex, it stimulates the secretion of these glucocorticoid hormones. Now, ordinarily, you would regulate that in sort of a negative feedback. As the glucocorticoid level rises, you secrete less CRH and ACTH, and as the glucocorticoid level falls, you secrete more CRH and ACTH. But the hypothalamus is also sensitive to other stimuli, and one of the main ones is stress. So when you are stressed, your hypothalamus responds to those stress signals from the higher brain by secreting more CRH. So when you secrete more CRH with stress, your glucocorticoid level starts to rise. And we're going to refer to this later when we talk about the general adaptation syndrome. Glucocorticoids have a couple of major functions. They do accelerate the availability of glucose in the body. Again, that in stressful situations is helpful if you are activating your fight or flight response. Even in normal levels of activity and stress, you need a certain amount of glucocorticoids to stimulate the normal metabolism associated with glucose. Additionally, glucocorticoids do have some anti-inflammatory effects. This may seem odd to you. The way I like to think of it is when you're stressed, that's when you need to be able to have maximum mobility and vision, so you wouldn't want a lot of swelling in your joints around your eyes to reduce your ability to respond to a physical threat. Regardless of the underlying adaptive benefit, the anti-inflammatory effects of steroids are really quite potent. And we use steroid anti-inflammatory drugs, SAIDs, S-A-I-D, quite a bit. They do have side effects, though, of course. And so one of the side effects is facial swelling, actually, with an excess. That very thin band of tissue between the main part of the adrenal cortex and the adrenal medulla is the zona reticularis. The cells here are reticular, that is, they have a network-like appearance. And this very small band of tissue produces androgens under the stimulation of ACTH. So you might remember the primary androgen is testosterone. Testosterone does help build bone and muscle and blood, and so perhaps it has some adaptive benefit in that way. In addition to the glucocorticoids being secreted with stress. However, if you have a tumor of the adrenal cortex, then you may have an overproduction of these androgens. In a female, it will lead to development of masculine traits. In a child before puberty, it will lead to the development of puberty at an inappropriately early age. Moving on to the adrenal medulla, this layer, remember, is really specialized nerve tissue. It is directly connected to the sympathetic nerves coming from the spinal cord. And while there are two types of cells, one secreting epinephrine and the other secreting norepinephrine, for the purposes of an introductory course like this, the effects of epinephrine and norepinephrine overlap so much that you really don't need to distinguish between them. So epinephrine and norepinephrine are going to, remember, augment and prolong your fight or flight response. They're going to make glucose more available for your skeletal muscles. They're going to make, therefore, energy more available for your skeletal muscles. In your adipose tissue, they're going to cause the breakdown of fat reserves. That's going to release fatty acids into the blood to fuel a lot of your other cells so that the glucose is available for your brain and your skeletal muscles. So it's definitely part of your fight or flight response. In the liver, epinephrine causes the breakdown of glycogen. Again, that releases glucose for fuel. Your brain and spinal cord, your neural tissue, really can't rely on anything besides glucose for metabolism. So in a stressful situation, if your skeletal muscles are using more glucose, you have to still make sure there's enough to feed your brain. And then in the heart, the beta receptors of the heart stimulate an increased rate and force of contraction. And you already knew that. Your fight or flight response causes your heart to beat faster and stronger. So we've talked about the adrenal cortex hormones, we've talked about the adrenal medulla hormones. These hormones are responsible for what we call the general adaptation syndrome or stress response. And stress can be acute or chronic. Acute or rapid onset stress is going to start with an alarm phase. And if the stress is resolved before you get past that phase, then you're done and you're over it. But if you have a prolonged stress, a chronic stress, then you're going to move from the alarm phase to the resistance phase. And in really serious cases, typically things like starvation or deprivation, then you're going to get to an exhaustion stage. And at that point, the body's lost its ability to cope. Let's see the mechanisms of the alarm and resistance phases. In the alarm phase, this is your fight or flight, and you learned about it in A&P1 when you studied the sympathetic nervous system. Now we're just looking at the hormonal effect. So your brain interprets the stress. Sympathetic stimulation actually, of course, has to come down the spinal cord to get to the adrenal medulla. And the adrenal medulla, remember, secretes epinephrine and norepinephrine, which gives you those physical responses that we associate with being stressed. You sweat, your heart pounds, you shut down your digestive and urinary systems, not completely, but you certainly reduce them. You send your blood supply to your skeletal muscles, and you mobilize your metabolic reserves. And increased mental alertness is a nice effect. You might remember that when you're studying for a test, that actually a little bit of stress makes your brain work a little better. Not too much stress. Now, in prolonged stress, you move into a chronic stress management phase called the resistance phase. And look at what's happening here. You still have that sympathetic stimulation because you're still stressed, but you have, in addition to the fight or flight response of epinephrine and norepinephrine, you're also going to get from the pituitary, from the hypothalamus to the pituitary, you're going to get that secretion of ACTH, which is going to stimulate the adrenal cortex to secrete glucocorticoids. Remember what they're going to do? They're going to raise your blood glucose level, make energy more available to your body cells for physical reaction to stress. You're also going to conserve salt and water through effects on the kidneys. You're going to raise your blood pressure. We'll study these systems later. And in the pancreas, you're going to secrete a hormone called glucagon, which we're going to talk about. Glucagon, again, helps mobilize your energy reserves so that when you're in a prolonged stress situation, you have the reserves you need for physical activity. Whether you're going to be physically active or not, your body's going to prepare for physical activity. So looking back at the alarm phase, the main hormones were the hormones of the adrenal medulla, epinephrine and norepinephrine. In the resistance phase, the main hormones are from the adrenal cortex, the glucocorticoids. And this is sad, but in the exhaustion stage, you're just beyond coping. Without direct medical intervention or other physical intervention, you're simply not going to survive. Okay, well that wraps up our study of the adrenal gland. We're going to move on to the pancreas. We're going to find that there are two hormones that are the most important hormones of this endocrine organ. The pancreas, as you're probably aware, lies inferior to the stomach and is nestled in the curve of the duodenum, kind of hiding up under the liver. It does contain predominantly exocrine gland cells. Remember, exocrine glands have ducts and they secrete a product onto a body surface or into a body cavity. In the case of the pancreas, the exocrine function is with the digestive system, so we'll worry about it later. So here you can see the pancreas nestled against the curve of the duodenum, and you can see the ducts of the pancreas. Again, that's their exocrine function. Over 90% of the pancreas is actually going to be involved with digestion, that exocrine function, and only about maybe 5% or so is involved in the endocrine function. The endocrine cells of the pancreas are organized into little clusters called pancreatic islets, or the islets of Langerhans, Langerhans being the guy that first described them. There are 4 kinds of cells. We're only really worried about the alpha and beta cells. The delta cells produce a hormone that is the same hormone that the hypothalamus secretes to inhibit growth hormone. Growth hormone is involved in, of course, growth, but it does have a role to play in mobilizing glucose reserves, so there's a regulatory element here in the pancreas. Our F cells secrete a hormone that regulates digestion, so we'll worry about digestive hormones when we do the digestive system. So here you see a micrograph showing you one of these little clusters called the pancreatic islets. If you were a trained microscopist, you could tell which ones were the alpha and beta cells. For the purposes of this course, it doesn't really matter. Okay, so we're going to talk about regulation of glucose, and as we do, we'll talk about those 2 primary hormones, insulin and glucagon. When you've eaten a meal, your blood sugar starts to rise as you absorb the glucose from that meal. Glucose is digested from the starches and glycogen in your meal. You're, of course, going to be absorbing other things with that, including amino acids from any proteins that you've eaten. So it's not just the glucose that has this effect, but when glucose levels rise after a meal, the beta cells of the pancreas secrete insulin. And insulin's effect on many body cells is to increase the intake of glucose into those cells. Very pronounced effect on skeletal muscle cells. So if you've just eaten a meal and your blood sugar's high and you're secreting insulin, then your skeletal muscle cells are absorbing a lot of that glucose because it's at a high level. And that will help bring the glucose level back down. If it's been a while since you've eaten, your glucose level may be dropping, then the alpha cells secrete glucagon. And glucagon is the antagonist to insulin. That is, it brings your blood glucose levels back up, mostly by stimulating the liver to release the stores of glucose. So in this diagram, you can see the effects of insulin. When glucose level rise, remember that's after a meal, the beta cells secrete insulin. It affects the ability of the cells to take in glucose. That allows them to use glucose. In the liver and skeletal muscles, it stimulates the conversion of glucose to glycogen. Remember, glycogen is the storage form of glucose. It also does increase amino acid absorption, and that then makes more amino acids available for protein synthesis. And in the adipose tissue, it stimulates an increase in production of fat. So when you've just eaten a meal, insulin tells you to put away the groceries, put the glucose into glycogen, put the fatty acids into fat, put the amino acids into protein. At the same time, you get to burn more glucose because there's more of it available. Notice the normal blood levels, 70 to 110 milligrams per deciliter. Now, if it's been a while since you ate, your blood glucose levels are falling. The alpha cells secrete glucagon. Glucagon stimulates the liver. I don't think it really does stimulate skeletal muscle at all. I think that's a mistake in the book, but it definitely stimulates the breakdown of glycogen to glucose in the liver, and the breakdown of fat and fatty acids in the adipose, and a special process by which liver cells can actually create new molecules of glucose, converting fat and amino acids into glucose. And that's going to bring your glucose level back up to the normal level. Remember that nerve tissue will not metabolize anything other than glucose, so this glucagon response is essential in maintaining normal blood glucose levels. If they fall too low, you may lose consciousness and in fact die if the glucose drops abruptly and you lose consciousness before you get a chance to eat something to raise your glucose level back up. Okay, so we're going to look specifically at what insulin does. We've looked at the regulatory mechanisms for both insulin and glucagon. Insulin, being released by beta cells, has as its target cells many cells of the body. And in those cells, it's going to, this is the primary effect, it's going to turn on the carrier proteins in the membranes of those cells and allow them to absorb glucose from the blood. Once that glucose is in those cells, well then naturally they can use it. They can use the glucose to produce ATP. They burn it for fuel. In the liver, it stimulates glycogen formation. In the skeletal muscle as well. And in liver and skeletal muscle and many other cells, it stimulates an increase in the absorption of amino acids, and that means those cells can then make new proteins. And in the adipose, it stimulates the storing of the fats. Glucagon, remember, is going to do the opposite. Released by alpha cells, just kind of re-releases all of those stored fats and glycogen and even breaks down protein. So in addition to getting the glycogen broken down in the liver, it's going to stimulate the production of glucose from fatty acids and amino acids. That process is called gluconeogenesis. The neo tells you you're making new glucose from something that wasn't a carbohydrate, an amino acid or a fatty acid, and of course breaks down your fat reserves. Now, we're going to talk briefly about diabetes mellitus. We just really can't get involved in all the metabolism of it. We'll talk about it again perhaps when we do the metabolism story. Diabetes occurs typically because of a mistake in the body's response or secretion of insulin. And the first sign of diabetes typically is you're going to the bathroom a lot, you're thirsty. And when the urine is tested, in fact, you don't even necessarily have to test it. Sometimes you can smell how sweet the urine is. So this is sometimes called sugar diabetes because of all the sugar that's in the urine. And the reason there's so much sugar in the urine is it's the kidney's job to reabsorb that glucose from the blood, but the blood glucose is too high, the condition called hyperglycemia. The blood glucose is so high that that glucose literally spills out of the blood into the kidney tissues and can't be reabsorbed. So the two types of diabetes mellitus, type 1 and type 2. Type 1 is also called insulin-dependent This used to be called juvenile diabetes, but these days, for some reason, we're seeing type 1 diabetes develop in adults. I'm not really sure why. Don't know of anybody that's really sure why. But the beta cells of the pancreas seem to be dying off. And it could be an autoimmune disease. The immune system is attacking the beta cells and killing them off. By the time you're aware of it, it's usually too late. And in fact, they're talking now about testing for this, early testing insulin levels in people who might have a family history of type 1 diabetes to see if they can identify it at an earlier stage and put them on an autoimmune treatment so that they can preserve their natural beta cell function. So if the beta cells are gone, you're not producing insulin, you need insulin to survive. And because insulin's a protein hormone, your stomach acid would digest it. You have to take it by injection. Type 2 is the non-insulin dependent diabetes. In people with type 2 diabetes, they're producing insulin, their cells are just not responding to it. For the most part, these people are overweight, although we do see cases of people with normal weight with type 2 diabetes. For the most part, it's people who are overweight. And what we're finding is that if we can get them to drop the excess weight, then they don't need to be treated for type 2 diabetes. It kind of cures it. Intriguingly, we're finding that people that have certain gastric bypass procedures are surgically cured of their type 2 diabetes pretty much overnight. So stay tuned. We're going to be learning more about what it is that the stomach's doing, that removing the stomach or stapling the stomach is curing type 2 diabetes. So some of the complications of diabetes mellitus: the kidneys degenerate, the retina degenerates causing blindness, the heart suffers mostly because of vascular damage in the heart. You have both nerve problems and vascular problems. So in the kidneys we have diabetic nephropathy or nephropathy. Nephro means kidney. In the retina it's diabetic retinopathy. Heart attacks due to blockages in the cardiac circulation. That's actually problems in the coronary vessels, the blood vessels that supply the heart. Diabetic neuropathy in the nerves. The problems with the limbs, usually the feet first, is the blood flow is very poor, so you have vascular problems, peripheral, a lack of good peripheral blood flow. The peripheral neuropathy is associated with that. So people with this complication don't feel pain in their feet, and even just tying their shoes too tight or getting a small cut on the foot can lead to an infection that's not going to get that's not going to be dealt with because their blood supply is so poor, and they don't feel any pain, so they're not alarmed by these injuries. And this is predominantly why diabetics tend to have amputations. So the nerve damage, again, reduces the blood flow, causing ulcerations, and because the surgery has to heal, the surgeon often has to cut much higher on the limb than you might think they should. And if they cut, say, at the knee and the wounds won't heal, then they have to go back in surgically and cut even higher.